GI bleed, gastritis, and peptic ulcer disease. The learning objectives for this module are explain the common etiology, clinical manifestations, and nursing management of upper GI bleeding, gastritis, and peptic ulcer disease. Upper gastrointestinal bleeding, or bleeding from the upper GI tract, is usually characterized by sudden onset and can be very severe. Bleeding from the esophagus is most likely due to chronic esophagitis. It can also be caused by GERD, irritating medications, alcohol, cigarette smoking. Also esophageal varices, which most often occur secondary to cirrhosis of the liver, can cause upper GI bleeding as well. Bleeding peptic ulcers account for 40% of the cases of upper GI bleeding. Typically these are caused by medications such as NSAIDs, aspirin, corticosteroids, and this is because they irritate and disrupt the mucosal barrier. Less common, you can see upper GI bleeding caused by tumors and vascular lesions. Bleeding from an arterial source is profuse and the blood is bright red. This is typically because it has not been in contact with the gastric hydrochloric acid. Coffee ground emesis indicates that the blood has been in the stomach for some time. Melena, or black tarry stools, indicates a slow bleed from the upper GI source. The longer the passage of blood through the intestines, the darker the stool color. This happens because of the breakdown of hemoglobin and the release of iron. There can also be occult bleeding, which means that there are very small amounts of blood in the gastric secretions. Typically these are not visible to the eye, but can be detected by a guaiac test. Endoscopy is the primary tool for diagnosing the source of bleeding. An angiogram is used in diagnosing upper GI bleeding when the endoscope cannot be done or when bleeding persists after the endoscopic therapy has occurred. To do an angiogram, the patient must be stable. Additional studies can be done to help determine the severity of the GI bleed. You're going to monitor the patient's labs, and this will help determine the effectiveness of the treatment as well. You'll look at a patient's CBC and evaluate their hemoglobin and hematocrit levels, and this helps to estimate the degree of blood loss. It can also help you determine if the patient is having increased bleeding or if the bleeding is subsided. You'll also assess the patient's BUN level. And during a significant hemorrhage, blood proteins are broken down by the GI tract, resulting in elevated BUN levels. Electrolytes typically may be out of whack as well, and this can be because the patient has had a severe amount of emesis or stool. We'll also evaluate the protime, because an elevated protime can increase the risk for bleeding. We'll look at a patient's liver enzymes, because a patient in liver failure increases their risk for esophageal varices. We'll be monitoring their arterial blood gases, so we can monitor their respiratory status. We'll also do a cross-match and a blood type in case the patient needs a blood transfusion. And we will also guaiac any of the stools or the emesis to look for microscopic blood. Nursing assessments will have an emphasis on the ABCs. The assessment should include the patient's level of consciousness. Vital signs are very important: peripheral pulses, perfusion, presence or absence of neck vein distension, and abdominal assessment, including assessment for distension, guarding, and peristalsis. Immediate determination of vital signs is important and can indicate whether the patient is in shock from blood loss. It also will provide the baseline blood pressure and pulse for monitoring treatment and progression throughout the treatment. You should know the signs and symptoms of shock, which can include low blood pressure, rapid weak pulse, increased thirst, cold, clammy skin, and restlessness. And typically you're going to monitor the patient's vital signs every 15 to 30 minutes, and you're going to inform the healthcare provider of any significant changes. You will continue to do frequent respiratory, cardiovascular, GI assessments, including the intake and output of the patient, and you're going to assess for continuing emesis or bloody stools by the patient. Treatment for GI bleed will consist of making the patient NPO. Our goal will be to rehydrate the patient, so we will insert an IV. It'd be best to have 2 large bore IVs. Oftentimes the patient will get lactated ringers, and you can anticipate that the patient will most likely need a blood transfusion. You want to observe the older adult or the patient with a history of cardiovascular problems closely for fluid overload. But you also must remember that fluid overload and pulmonary edema can happen in any patient who is receiving large amounts of IV fluid or blood products in a short amount of time. So when you're watching for fluid overload, you're auscultating breath sounds, you're observing respiratory effort. It'd be a good idea to keep the head of the bed up and watch for any signs and symptoms of aspiration. You'll also be monitoring urine output to make sure that the urine output closely matches the amount of fluids that is being given intravenously. You'll also suspect that the patient will get an IV infusion or receive IV push proton pump inhibitors. Typically, Protonix is a medication that is commonly used. The first-line management of upper GI bleeding is endoscopy with endotherapy. It is most helpful if the endoscopy is performed within 24 hours of bleeding. This is important to diagnose and to provide any surgical or radiological intervention. The goal of endoscopic hemostasis is to coagulate or thrombose a bleeding vessel. Sometimes it'll be necessary for a patient to have an NG tube inserted to do lavage prior to the procedure in order to remove large amounts of blood from the stomach. Patients with upper GI bleed should be taught to quit smoking. They should avoid alcohol, try to decrease their stress, and they should be very careful with using any over-the-counter medications. They must know that it's very important that they take the medications to prevent GI bleed that are prescribed by their physicians or healthcare provider. They should know the signs and symptoms of upper and lower GI bleed. And they should know the side effects of any medications that they go home on that may increase their risk for bleeding, such as aspirins, NSAIDs, and other anticoagulants such as Coumadin. Gastritis is one of the most common problems affecting the stomach. It is the inflammation and breakdown of the normal gastric mucosal barrier by hydrochloric acid and pepsin. Gastritis can be acute, chronic, diffuse, or localized. It is typically caused by certain medications such as aspirins and NSAIDs, diet, which can include alcohol and spicy foods, microorganisms such as H. pylori, smoking, and you can also be caused by hiatal hernia or stress. In acute gastritis, the symptoms include anorexia, nausea, vomiting, epigastric tenderness, and a feeling of fullness. Hemorrhage is commonly associated with alcohol abuse and at times is the only symptom. Acute gastritis is typically self-limiting, but usually lasts only a few hours to a few days, and there's typically complete healing of the mucosa. In chronic gastritis, the symptoms are similar to those described as for acute gastritis, but sometimes the patients are asymptomatic. The diagnosis of gastritis is most often based upon the patient's history of drug and alcohol abuse and their signs and symptoms. But an EGD or an endoscopy with a biopsy may be warranted to obtain a definitive diagnosis. Treatment for acute gastritis is very similar to nausea and vomiting. Depending on the severity of the patient may just be NPO and receive some IV fluids. The patient may have an NG tube inserted in order to keep the stomach empty. Typically, clear liquids are resumed when symptoms subside. Treatment for chronic gastritis typically focuses on evaluating and limiting the specific cause. So if it's alcohol and smoking related, patients would be instructed to discontinue those activities. So teaching for patients with both acute and chronic gastritis most often focuses on diet modification, decreasing alcohol intake, smoking cessation, if they have H. pylori, treating the H. pylori, and typically the patient will need to be on a proton pump inhibitor. Peptic ulcer disease is a condition characterized by the erosion of the GI mucosal resulting from the digestive action of hydrochloric acid and pepsin. It can be acute or chronic, can be gastric or duodenal. It is typically caused by H. pylori, alcohol use, cigarette smoking, stress, and the use of aspirin and NSAIDs. This image shows you the erosion caused by the hydrochloric acid and the pepsin. Chronic ulcers can eventually penetrate the entire wall of the stomach. Here you have an image of a peptic ulcer of the duodenum. The discomfort generally associated with gastric ulcers is located high in the epigastric region and typically occurs 1 to 2 hours after eating. The pain is described as burning. The patient feels very gaseous. If the ulcer has eroded through the gastric mucosa, food tends to aggravate the pain. For some patients, the earliest symptoms are due to serious complications such as abdominal perforation. The symptoms of duodenal ulcers occur when gastric acid comes in contact with the ulcers. When meals are ingested, food is present to help buffer the acid. Symptoms of duodenal ulcers occur generally 2 to 5 hours after eating. This pain is described as burning and cramp-like. It is most often located in the mid-epigastric region beneath the xiphoid process, but duodenal ulcers can also produce back pain. The diagnostic tests used to determine the presence and location of an ulcer are similar to those used for the acute GI bleeding. Endoscopy will be the most accurate diagnostic procedure. Additional laboratory tests may be similar to GI bleed as well. You're going to have a CBC. You'll be looking to see if the patient is anemic, and this could be secondary to a bleeding ulcer. You may be looking at their white blood cell count to see if there is an infection. You also will look at liver enzymes to detect if there are any liver problems, which may complicate treatment and also increase the risk for esophageal varices. You'll also look at a serum amylase, which can determine if the pancreas is involved. In most cases, patients with uncomplicated peptic ulcer disease are treated as an outpatient. Whether they're inpatient or outpatient, typically they're told to rest the stomach, so they would be NPO and then slowly start eating, starting with clear liquids and advancing. It would teach the patients to avoid food that cause gastric distress, such as spicy or acidic foods. They should have alcohol and smoking cessation education provided. They should know the side effects of over-the-counter medications and be instructed to avoid medications such as aspirin and NSAIDs. They'll probably be put on a proton pump inhibitor or H2 receptor blocker, and they should be instructed on the importance of taking that medication as prescribed. They should be instructed to decrease their stress and be given some stress management teaching, and they should also know the signs and symptoms of recurrence. There are 3 major complications of chronic peptic ulcer disease. These include hemorrhage, perforation, and gastric outlet obstruction. All are considered emergency situations and may require surgical intervention. Hemorrhage is the most common complication, and typically the patient presents with vomiting of blood and there is a change in vital signs. Perforation is the most lethal, and most times it's the most lethal because of the high risk for infection if the stomach perforates or the intestine perforates. Typically the patient is going to have severe, sudden pain. They may be found with their knees pulled into their stomach, and they'll have grunting respirations. Gastric outlet obstruction, the patient typically has nausea and vomiting. They may have abdominal distension, and the abdominal distension continues despite having a nasogastric suction tube placed. If a patient is hospitalized with peptic ulcer disease, typically they'll be NPO. They may or may not have an NG tube placed. They will be getting IV fluids. If some of the complications arise, such as hemorrhage, the goal will be to stop the bleeding. Whether that means that the patient needs to have surgery or the bleeding can be stopped through an endoscopic procedure, the goal would be to decrease the bleeding, stop the bleeding. We would also need to restore blood volume, so you would anticipate providing a blood transfusion for this patient. If perforation occurs, we want to close the perforation and stop the bleeding, so this patient will definitely need to have surgery of some sort. They will also need to have their blood volume restored, and because they've had a perforation, they will need to be on antibiotics. If the patient has a gastric outlet obstruction, they will need an NG tube to decompress the stomach. They will need fluid and electrolytes as well. Surgery for peptic ulcer disease is uncommon and is typically only performed on patients who have complications or patients that are unresponsive to medical management. There are 3 types of surgical procedures. This includes partial gastrectomy, vagotomy, and pyloroplasty. Gastrectomy is the partial removal of the lower 2/3 of the stomach. Vagotomy is the severing of the vagus nerve, either totally or selectively, and this is done to decrease gastric acid secretion. Pyloroplasty consists of surgical enlargement of the pyloric sphincter to facilitate easy passage of contents from the stomach. As with all surgeries, postoperative complications such as bleeding, infection, and the other postoperative complications spoken about previously can occur. But patients who are having surgery for peptic ulcer disease can also experience dumping syndrome, postprandial hypoglycemia, and bile reflux gastritis. Dumping syndrome is a direct result of the surgical removal of a large portion of the stomach. The stomach no longer has control of the amount of gastric chyme entering the small intestine. So a large bolus of hypotonic fluid enters the intestine and results in fluid being drawn from the bowel. This creates a decrease in plasma volume along with distension of the bowel lumen and rapid intestinal movement. The onset of symptoms typically occurs within 15 to 30 minutes after eating. The patient usually describes the feelings of generalized weakness, sweating, palpitations, and dizziness. Postprandial hypoglycemia is a variant of dumping syndrome, and it occurs because of the result of uncontrolled gastric emptying of a bolus of fluid high in carbohydrate into the small intestine. The bolus of concentrated carbohydrate results in hyperglycemia and the release of excessive amounts of insulin into the circulation. So this high release of insulin into the circulation results in reflex hypoglycemia. So the signs and symptoms are typically those of hypoglycemic reaction, and they can usually occur 2 hours after eating. Another complication is bile reflux gastritis, and this happens when the surgery involves the pylorus. There is prolonged contact with bile, which causes damage to the gastric mucosa, chronic gastritis, and the recurrence of peptic ulcer disease. The symptoms typically are associated with reflux alkaline gastritis and typically happen after meals. If a patient vomits, the symptoms are typically relieved, but this is only temporary. Care of the patient after abdominal surgery is similar to caring for any postoperative patient. There will be a GI focus. Your assessments will include head-to-toe assessments, but you will have a focus on the signs and symptoms of decreased peristalsis, including abdominal distension, lower abdominal discomfort. You will be watching for abdominal intestinal obstruction. You'll be recording intake and output. You'll be managing pain. It is likely that the patient will have an NG tube, so you will need to care for the NG tube. You will need to make sure that there is proper suction. You'll be monitoring the intake and output, and you'll be maintaining IV therapy.